Good evening, everyone. Pharmacists, members of PSK, karibuni sana. My name is Eric Muringu, and I'll be your host today for this particular webinar. As you know, the topic, you must have seen it, anticoagulation in venous thromboembolism. This is sponsored by Bayer. Thank you, Bayer, for sponsoring this webinar. We are going to have 1 hour and 30 minutes of an interactive session, scientific presentation, and also market conscious presentations. Then we'll have a question and answer. So I'll take you briefly through the ground rules of what you're expecting today. This is usual, this is in-house, our routine housekeeping, that you're going to be muted during the course of the presentation. For every question that you have, you can type on the Q&A tab at the bottom of your screen. This will be addressed by the presenters at the end, but some can be answered directly if there is that need. For all of you, I'm asking you to subscribe on the PPB portal. That's how you'll be able to secure your CPD points. These points, you'll receive your token within the next 2 weeks. So the event will run for 1 week. Then after that 1 week, we'll send the tokens. This session is recorded and it's available on YouTube channel or PSK YouTube channel, as there are many others like that. So this is the page where you are going to subscribe on the PPB portal. Many people ask when they receive the token that they cannot see the event, because if you look, the first event on that screen, this is page 9 of the CPD listed events. The date that is put there, it's 17th to 24th, that's a week. It's going to appear for that whole week. So you have a whole week to subscribe. You can subscribe now, but not later than a week from now, because it won't be available. When I send tokens, some of you are asking, I can't find the event on the PPB portal, but the event expired after a week. So this is the time to subscribe, not when you receive the token. I hope that's clear. That is on page 9 of the PPB list of events. So we are going to have a presentation by Dr. Jones Makori. I'll introduce Dr. Jones Makori. He is a practicing pharmacist at Coast General Hospital. He's been there for some years. I'm an active member of Coast Branch. Dr. we are honored to have you. We are looking forward for the presentation. Then we'll have Elma Barasa of Bayer making the second presentation, after which we'll have question and answer. Then we close the meeting, not later than 8:30. So I'm asking you to sit back and relax, enjoy the learning. Then we'll have, if you have any question during the presentation, you can type it, not on the chat, but on the Q&A. That's how we can easily access the questions. So thank you very much. Karibu sana, Dr. Jones Makori, for your presentation. Allow me to stop sharing my screen so that now you can take over. Karibu, Daktari.
Thank you. I hope my screen is now on.
Yes, it is.
Fortunately, I'm not seeing it from this other side. minutes. All right, thank you. So thank you, members, for joining in. As I've been introduced, my name is Makori Jones. I am a pharmacoepidemiologist based in Kobe General Hospital. Today's topic is likely a continuation of a series of meetings that we've been having on venous thromboembolism. And today we want to focus on the impact of pharmacist intervention in anticoagulation therapy. Now, for those of us who practice for some time, we know this is one area that most of our pharmacists have not ventured into, or if they have really ventured into this area, there is no documentation of the work and the impact the pharmacists have had in this particular area. And if there's no documentation of the work that has been done, it means we're not able to qualify, neither can we quantify the work that has been done. So it is a reminder of what we pharmacists can do, the intervention that we can have in anticoagulation therapy. So welcome on board. My overview of my presentation, briefly, we're going to look at anticoagulation in general, review the role of pharmacists in anticoagulation therapy, and then see some of the impact of pharmacist-led intervention in other parts of this world where pharmacists have taken a lead role in anticoagulation therapy. And why I brought in the role of pharmacists, we cannot understand the impact if we do not understand our role in anticoagulation therapy. So venous thromboembolism is actually a serious medical condition where blood clots in the veins, and at times this clot may break loose, move to the lungs, causing what is known as pulmonary embolism. Now, most cases of VTE are not known. 50% are idiopathic. And among the common VTE, deep vein thrombosis is the common one. And normally it can occur in the arm, in the felt region. And at times, it can also occur in the area of the arm, but mainly it is in the leg region and the pelvic region. Now, why we are concerned about VTE is because of the prognosis of the condition. In most patients with upper part DVT are usually at a long-term risk of developing chronic venous insufficiency. And about 20% of these untreated proximal DVTs can easily progress to become pulmonary embolism, whereby 10 to 20% of these are actually very fatal in patients. And one of the key things in prognosis, that in some of these patients who develop pulmonary embolism, the first sign they know that they have a pulmonary embolism actually is death. So that is why it is very important that it is identified in good time and appropriate treatment and prophylaxis given so that to prevent these fatal end results. The good news is with aggressive anticoagulation therapy, usually the mortality can be decreased by between 5 and 10 times. And normally, DVT that is confined to the lower part of the leg does not usually cause major clinical problems. We are worried about the one that happens in the proximal region. Now, also, it is important for us to understand some of the risk factors for developing of deep vein thrombosis. Some are associated with altered blood flow, or what we can call circulatory stasis or venous stasis. Some emerge from endothelial injury, and some due to hypercoagulability of the blood. Among the major hypercoagulability include patients who have undergone major surgery, patients with various types of cancers or malignancy, sepsis, patients who are on certain medications such as estrogen-based oral contraceptives. In venous stasis, the contributing factors include those patients who have prolonged their bed rest, or patients who have a cast on their leg, or immobility due to one or another reason. Among the endothelial injury factors, or what we can call vascular damage, like patients who have cellulitis or patients who have catheters are likely to develop deep vein thrombosis. So when you are assessing for the risk, we have to look at these factors. Are there any of these contributing factors to deep vein thrombosis, so that we can do a risk stratification? Again, it is important to understand some of the complications that arise from improperly managed DVTs. One of them is acute pulmonary embolism. And as we've said, pulmonary embolism is a vital condition. 2 is post-thrombotic syndromes. 3 is where we have a clot in the brain. Or at times, you can have a clot in the heart, which can cause heart attack. Or at times, if it happens in the brain, the patient can develop a stroke. And lastly, an issue to do with chronic venous insufficiency. So what is anticoagulation medication? Anticoagulation medications are the first defense line against clot formation, and they help protect patients from clots. And for many years, these medications have been available. The first medication being used clinically almost 80 years or 90 years back. So basically, what do anticoagulants do? They stop clot formation, hence preventing venous thromboembolism, preventing episodes of heart attack, and also stroke that happens in the brain. So a brief history of anticoagulants. The first anticoagulant was heparin, unfractionated heparin, that was discovered in the 30s, early 30s, and still it is in use. Has been an effective anticoagulant agent, so long as it is used according to prescriber's information. The only drawback of unfractionated heparin is that it has to be given by injection. The second anticoagulant to come in place was the vitamin K antagonist, and the main drug we normally use is warfarin. And it is one of the most effective drugs, so long as international normalized ratios are maintained within the required range for the indication. And it can be given by oral route, unlike heparin that has been given by, which has to be given by injection. The major drawbacks of this drug, vitamin K antagonist, is one that it requires regular monitoring and titration of dose. INR has to be taken on a regular basis, and based on that, the doses have to be titrated. Number 2, it requires regular dose adjustment based on patient response, thereby requiring that the patient has to go back to the clinician or the physician on a regular basis. 3, it has also many food and drug interactions. Actually, from literature, they say warfarin is known to interact with more than 595 different drugs and food supplements, out of which 135 are serious interactions. The other anticoagulants is the raw molecular weight heparins, the enoxaparins, which came into use in the 1980s. And they're one of the mainstream treatment and prevention of DVTs. They're very effective when used as per prescriber information. The only drawback is that it has to be given by injection. And at times, for those who have renal impairment or any renal condition, they have to be used with a lot of caution. The other agents are the non-vitamin K antagonist oral anticoagulants, or the NOACs, and they can be direct inhibitors of activated factor 10, like rivaroxaban, abixan, and enoxapan, or direct tropin inhibitors, like the Bigatra. Now, the major advantage of these drugs, they were able to overcome most of the limitation of the other older anticoagulants, especially when it comes to being given by injection, and also in terms that there are very low potential of drug-drug and drug-food interactions, and they have a very rapid onset of action. And major benefit to the patient is that it has predictable anticoagulation, so they do not require a routine monitoring, as in the case of the vitamin K antagonists. So what is the role of pharmacists in anticoagulation therapy? I know most of us have been in the field for quite some time. Unlike maybe other chronic diseases like HIV, like cancer, where pharmacists have been taking an active role and where we have registries, in the area of anticoagulation therapy, it is not the case. I know a few facilities have anticoagulation, active anticoagulation clinics like MTRH, KNH, and other few facilities. But really the role of pharmacists has not been felt in many other areas in terms of anticoagulation management. So quickly to review our role in this field. Number one is the routine care, maintenance, and management of therapy. 2, in patient education. 3, in managing transitions for management of anticoagulation therapy-related problems. And 5, in the area of pharmacoeconomics, where we can be able to do the CPA, or we can be able to carry out what we call assess the benefits, the cost-benefit analysis for the patient for the various interventions, or carry out cost minimization analysis, or cost effectiveness analysis for various intervention, or cost utility analysis, or we can also do what is known as queries, quality adjusted live years, which is actually a generic measure of the burden of disease, where you look at both the quality and the quantity. So it measures the value of the medical intervention we are giving for the particular patient. Now we go through each one of these in detail so that we can be able to appreciate our role, so that we can be able to know the impact that we can create in society. In routine care and management, that not only in hospital setting, but all of us, we know, even those practicing in community setting, we do interact with patients who are on anticoagulation therapy on a regular basis. The question we need to ask ourselves, do we ever follow this patient to find out how they're responding to the medication that we're giving? So it is important in the routine care and management that we maintain a patient profile and a monitoring registry for all patients who are on coagulation therapy. So in these patient profiles, we need to have the indication for anticoagulation therapy. Why are they on this particular therapy? What condition is being prevented or is being managed? What are the targets for the anticoagulation therapy? The duration of anticoagulation therapy. For some, it may be short-term. For some, it may be long-term. So we need to understand the duration of therapy. What are the drugs prescribed? Not only for anticoagulation, but for other conditions. Are there potential interactions? Are there potential or need to carry out drug reconciliations, dose adjustments? The relevant laboratory values that should be monitored and how they are interpreted, dosage adjustments, and medication reconciliation. So every time a patient visits for a refill of the prescription, you need to look at all these parameters so that you can be able to effectively manage the patient. In terms of laboratory monitoring, the patient needs to be aware the investigations that are required, both at initiation of therapy and during the course of treatment. Some may require baseline investigations before they start therapy, like the creatinine clearance or international normalized ratios, the INRs. And you also need to be aware of ancestral investigation that may be required, because maybe there's an addition of other medications that warrant rechecking of these laboratory values. Or when adjusting patient maintenance dose, you are stepping up the dose or you are lowering the dose. It's important to check the laboratory parameters. Wherever, especially with the warfarin therapy, where there is change in diet of a patient or activity level or the health status, then it is important to recheck the laboratory parameters to see that they're within the required ranges. In terms of patient education, that it is important for all patients who are enrolled in anticoagulation therapy clinics to receive both verbal and written educational materials regarding appropriate use of their anticoagulation medication. And some of the key information that need to be provided for the patient include the patient need to understand the reason for anticoagulation therapy. Many times, when patients are not empowered with information, they simply take this medication for a few days and then stop taking the medication. So they need to understand the reason for their therapy, the name of the medication they're using. At times, we assume that patients are illiterate, they cannot understand the names of the medication. But it's important, even when the patient is not able to pronounce the names correctly, at least to know how their drug look like, the strength, and other relevant information that may assist the patient. Then patient need to understand the potential implication of either too much or too little anticoagulation, why they need to take the drugs according to the instructions they have been given, the tests that are required and when they should be done, the targets, and targets should be set with the patient, taking into considerations the individual patient, then other key information include patients should know the symptoms of when the condition is worsening, especially when they may be experiencing breeding problems. For drugs that interact with food, they should know what are the food restrictions, especially when they're taking the vitamin K antagonists. And everything that you do for a patient must be documented. That if it's not documented, then it is not done. The other key area is managing transition. And this is where we find one of the biggest challenges in patient management. Transition can happen for a patient, maybe it was an inpatient and is due for discharge to continue management from home or from outpatient clinic, or it can be a transition from one anticoagulant to another. You're changing the drug, or it's a transition when there is an interruption of an anticoagulant agent for an invasive procedure. Maybe a patient has to undergo surgery or a dental procedure. All these transitions need to have protocols, and these protocols can be developed in conjunction with the physician and other healthcare team members. So the first transition is transitioning a patient to the NOACs. For patients who are on unfractionated heparin, you start the NOAC when the unfractionated heparin inhibition is stopped. So you don't give time. You start immediately once the unfractionated heparin has been stopped. From raw molecular weight heparins to the NOACs, they should be started at least 2 hours before the next scheduled dose for the raw molecular weight heparin. This is to allow for the pharmacokinetic process such as disintegration and absorption so that they can achieve the peak plasma concentration. For those who are transitioning from warfarin to the NOACs, it is recommended that you wait until the INR is below 2 to start treatment. When a patient is being transitioned from the NOACs to parenteral anticoagulants, a baseline investigation of the creatinine clearance should be done to guide when to start treatment with the parenteral anticoagulants. So for those with a creatinine clearance of more than 30, then you can start 12 hours after taking the last dose of the NOAC. Remember, NOACs have an effect on the renal functioning. When there is deranged renal functioning, clearance of the NOACs tend to be very slow. They tend to have longer elimination half-lives. For those with creatinine below 30, you can start the parenteral anticoagulant at least 24 hours after the last dose of the NOAC. From the NOAC to warfarin, again, we have to do a creatinine clearance. If it's more than 50, start warfarin 3 days before the NOAC is stopped. So there's overlapping therapy when you're starting warfarin to allow warfarin normally for activity to set in. It takes a number of days. That is why it is given overlapping with the NOAC so that it can start eliciting its activity. For those with the creatinine between 31 to 50, normally it's recommended that we start warfarin 2 days before the NOAC is stopped. And for those of a creatinine between 15 to 30, normally 1 day is usually recommended. Now, if there's a transition from NOAC to the warfarin, usually overlapping therapy is crucial. And this is to ensure proper anticoagulation. But in cases of vitamin K antagonists, warfarin and rivaroxaban, new evidence say that they can be given concomitantly, so you don't have to stop one and then give the other one. And rivaroxaban then can be stopped once the INR are above 2. So there are some circumstances when it is important to stop anticoagulation before major surgeries. For patients on NOACs, it is recommended that it should be stopped at least 3 drug half-lives prior to surgery. Those that have a long half-life, like the bigatran, they may require more than 40 hours before the surgery. For rivaroxaban, between 15 to 27 hours, apixan between 24 to 48 hours. And also take into consideration the age of the patient. If more than 75 years, they may require a longer period before the surgery. The integrity of the renal and lymphatic function, because it is metabolized in the liver and eliminated in the kidney. So in case of impairment, it tends to take a longer time, and the risk of bleeding also. So who are the candidates of choice for the new oral anticoagulants? It's recommended for those patients who have an unstable INR or warfarin is not maintaining the good due to poor compliance. For those patients who have adequate renal and lymphatic function. For patients with no mechanical valve, and in this case, patients who have replaced valves, the drug of choice is usually warfarin. The other agents have not shown good response. Either there will be too much coagulation or little anticoagulation effects. Now, in pregnant women, because these drugs cross the placenta, they may have an effect in the fetus. Patients who do not have extreme weight, because most of the NOACs, actually they come in fixed doses. So in cases where there's extreme weight, those adjustments may be an issue. And in those that do not have high risk of lower GIT bleeding. So the last area where our role should be felt in the area of managing anticoagulation problems, this including bleeding complication, thromboembolic complication, excessive anticoagulation. At times you may have subtherapeutic anticoagulation, or at times when there is interruption of anticoagulation for invasive procedures, surgeries, and in cases where there is non-compliance. So in case of bleeding, and a major bleed episode may occur, or it is termed when it occurs when there is an intraocular bleeding, or bleeding into the internal organs, retroperitoneal bleeding, or any CNS bleeding, or a bleeding which results in a decrease of hemoglobin by more than 2 units, or when there is bleeding that requires transfusion of more than 2 units of packed red blood cells. So one major concern with anticoagulants, especially the heparin-based anticoagulants, is what is known as heparin-induced thrombocytopenia, where there is a drop in the platelet count by more than 50% or more from the baseline. And usually it occurs between 4 to 14 days of heparin therapy. And usually it is associated with presence of venous or an arterial thrombotic event, and where you've ruled out any possible explanation of the thrombocytopenia. So what to do in an event of this case? It is recommended that all heparin should be stopped from all sources, whether it was given by, or is being given by IV subcutaneous, or it is being used for catheter flushing, or during the process of dialysis. It's recommended that blood sample is taken to assay for heparin-induced thrombocytopenia assay. Fortunately, we have an antidote for that in the name of fundaparinax. I don't know how ready it's available in most of our facilities. And usually, platelet transfusion is not recommended unless the bleeding is very significant. Where heparin is indicated, maybe it's a patient who momentarily was put on heparin, but is usually on warfarin, then the warfarin should be withheld until the platelets recover to at least above 150 or back to the baseline. In event of excessive anticoagulation, you need to know when to refer patients. For patients with an INR of more than or equivalent to 5, where you are using a point of care INR machine, this should be referred to the clinician for further assessment. Normally, it is recommended that a sample be drawn from the venous to assess whether it is an accurate reading or is a false reading. Now, in event where patients have subtherapeutic anticoagulation, usually it is recommended that the therapeutic plans are individualized. Assess the degree to which INR is subtherapeutic. Estimate the time the patient's INR may have been subtherapeutic, and then assess individual risk of thromboembolism and estimate the time required to reestablish the therapeutic anticoagulation. Now, again, subtherapeutic anticoagulation may be because of various reasons, especially for compliance or interaction with other medications. So you need to take a good history, both medical history and the nutritional history of the patient. As I mentioned, this may be due to non-compliance interfering medication or dosage confusion, where a patient may be using multiple medications. So conducting a medication reconciliation for these patients may be necessary to achieve the set therapeutic goals. So interpretation of INR results. Now for INR, normally it is set based on the condition that is being treated, but the normal range is between 2 and 3.5. For patients with INR ranges of below 2, they may experience clotting or thrombotic effects. For patients with INR ranges above 4 and 5, they may experience severe bleeding conditions. And if you can see from the graph, the blue line indicates mortality of normal population, while the red line indicates mortality when the INR range is not maintained within range. So as it moves further from 3.5 going to 6, 7, and 8, the risk of mortality also increases in these patients. And also as it goes below 2, the risk of forming clot also increases, hence increasing the mortality risk. So again, there are moments when there's a requirement to interrupt coagulation because of surgical procedures, maybe a dental procedure or a surgical procedure. This should be done in conjunction with the physician, and every patient should be evaluated for the risk of bleeding associated with continuous anticoagulation. depending on which procedure and the duration of the procedure to be done. Also, each patient should be evaluated for the risk of thromboembolism if anticoagulation is temporarily stopped. If thromboembolism risk is associated with stopping warfarin, then it is sufficient to warrant cross coverage with either unfractionated heparin or raw molecular heparin should be reviewed. Then last but not least, in management of the problem is management of drug-related interactions. Now, warfarin is usually metabolized by the cytochrome group of enzymes, and drugs that are either enzyme inducer or inhibitors may have an effect on the metabolism of warfarin, hence affecting the INR range. When you detect any potential interaction, then the pharmacist should be able to determine the best option for the oral anticoagulation therapy, either adjusting the drugs that the patient is using or adjusting the dose of warfarin that the patient is taking to take care of the interactions. Non-compliance is a big problem, especially with chronic condition. And compliance required a cooperative effort between the providers and the patient. And some of the factors that may have an influence on adherence include disease characteristics such as comorbidities. A person who may be on anticoagulation may have other conditions like hypertension, diabetes, and may be using maybe a whole lot of drugs, maybe 6, 7, or 8 drugs. The treatment regimens, either there are too many drugs or the cost of treatment is too much, or the drugs the patient is using comes with a lot of restrictions or with a lot of adverse drug reactions. Patients tend to be very selective on which drugs to use and which one to avoid once they know which one is responsible for the adverse drug reaction. Another factor is the patient-provider relationship. When there is a trust in the relationship, when the patient have confidence in the services they are receiving, they tend to have better adherence where they can be able to express their challenges and issues, and they get assistance from the providers. The clinical setting, like most in our community pharmacy setting, most of our community pharmacies actually lack friendly, supportive areas where they can talk with the patients in confidentiality. So we must aspire to improve our clinical settings so that they become more conducive for providing the services. Other variables will include age, education, and the medical experiences the patient have had. So for those on warfarin therapy, normally we can measure non-compliance by looking at optimal time in the therapeutic range. And normally it is recommended that 70% of the time the patient on warfarin therapy, they should be within the required therapeutic range. I have a few case studies, and these have been drawn from hospital setting. I have this case of Rema, who is a 28-year-old, who recently underwent prosthetic heart valve replacement 3 years ago. Since then, she's been on warfarin therapy. She recently got married, but unfortunately, every time she conceived, she experiences severe bleeding, and subsequently, she miscarriages. Now, she's been reading a lot about anticoagulation therapy, and she read about these new anticoagulants, the NOACs. Today, she comes to you. She's requested to be switched. Her ANR today is 5. What will you do for the patient? What will be a course of action? And what advice will you give this patient? So this is a young lady who is in reproductive age. Because of her condition, valve replacement, she's on warfarin therapy for 3 years. But unfortunately, because of the therapy, she's not able to conceive. So what advice and what is the next course of action? And these are really problems that people on anticoagulation therapy usually face. So the possible course of action, you need to assess for the bleeding, the extent of bleeding, because the INR is above 5. You need a confirmatory sample using venous blood. It is advisable to all warfarin dose. Check whether there is any change in diet, whether this change in INR will be because of drug or drug-food interaction. Take the patient through the benefits and harm of the various options that we have for treatment. The patient requires frequent follow-up. If she has to remain on warfarin therapy, then psychosocial support, because it's the right for everyone to have babies. And if they cannot conceive, then we need to have other plans. This is a case that requires referral to the primary physician who's taking care of the patient. And probably subcutaneous heparin will be an alternative for this particular patient. And something to note is that warfarin normally accords better protection for patients with valve replacement. But in women of reproductive age, they have high teratogenic potential, apart from these episodes of bleeding because of the changes in the INR. Case number 2 is James ML, 54-year, who is hospitalized post-coronary artery bypass grafting. He receives heparin infusion at a dose of 1,200 units per hour, administered for 3 hours. He begins complaining of lower extremity swelling and pain. The doctor orders for a Doppler, and DVT is ruled out, and extremity bleeding is suspected. What will you recommend as the next course of action for James? So this is a patient who is receiving heparin as a continuous infusion, and he complains of lower extremity swelling and pain. So what is likely the cause of this swelling and the pain that the patient is feeling? So for this patient, remember the issue we said about heparin-induced thrombocytopenia. So the first thing to do is to stop heparin drip. Luckily, we have an antidote for heparin, a protamine sulfate, which is given 1 milligram per 1,000 units of heparin that is given. So for the 1,200 units that have been given for 6 hours, which is equivalent to 3,000 units of heparin that have been given, you require 36 milligrams of protamine. If you give this dose of 36 milligrams of protamine sulfate and the bleeding persists, then consider giving another dose. Monitor the patient for any signs and symptoms of thrombosis. The last case is Salma, who is 52-year-old, a female, underwent a hip replacement a few days ago. She is still on enoxaparin, that is a raw weight molecular weight heparin, and she is now due for discharge. During the clinical ward rounds, she discloses that she has a phobia for injection. and she's not able to self-inject despite a demonstration by the nurse. What you would recommend to Salma? What would be the next course of action? This is a really case where some patients have fear for injection. And if they know it is going to be a long-term treatment, then they usually prefer an alternative. For hip replacement, we know it is a high-risk procedure where patients will require prophylaxis for a prolonged period of time, at least between 4 to 5 weeks. So for Salma, yes, it is a high-risk patient, and they require extended prophylaxis up to 5 weeks. You need to discuss the available options. If you agree with the patient that they are going to be on the directly acting oral vitamin K antagonist, then you need to start the first dose before discharge, at least 2 hours before the time that the next scheduled dose of enoxaparin is due. Now, another question, what if the patient was to switch to the vitamin K antagonist? It's a take-home question. Now, quickly, let's look at the impact of pharmacist intervention in anticoagulation therapy, which is our main area of focus today. Now, review of literature. I did not see any document or any publication from Kenya indicating the impact that pharmacists have had in this field. But from other parts of the world, there is so much that pharmacists are doing, and actually the impact can be felt. So impact of our intervention can be assessed in 2 critical areas. First, in healthcare expenditures, whether they're direct anticoagulation-related costs, overall medication care costs, hospitalization and emergency department fees-related costs, operational costs of anticoagulation services. Another impact area of assessment is in terms of therapeutic outcomes. In therapeutic outcomes, we can look at the area of anticoagulation-related adverse events, the frequency of hospitalization, frequency of emergency department visits, frequency of INL testing, and in the markers of anticoagulation control, that is time in the therapeutic range and percentage of INL values in the range. So various studies, I reviewed a number of studies, and one of the studies was looking at the healthcare expenditure and therapeutic outcomes of pharmacies managed anticoagulation services versus usual medical care. And this was published in the Journal of Pharmacotherapy in 2011. So they compared the costs and therapeutic outcomes where a pharmacy was reading the anticoagulation management versus routine or usual medical care. So the objective was to evaluate the differences in healthcare expenditures and therapeutic outcomes of patients receiving warfarin therapy management by a pharmacist managed anticoagulation service versus usual medical care. And this was a retrospective match cohort study in the University of Pittsburgh in the US. So there were a total of 335 patients who were divided in the 2 arms, 175 in the pharmacy managed service and the other 175 in the usual care. So the outcome that were looked at are the direct anticoagulation costs, overall medical costs, operational costs of anticoagulation services, the anticoagulation related adverse events, hospitalization and emergency department visits, frequency of INR testing, and the INR values and time within therapeutic range, and the quantity of warfarin refills. So what were the results from this study? In terms of costs, direct costs of anticoagulation, they were 3 times less, and 50% less for anticoagulation service group, that is a group led by pharmacists, compared to usual care group. So there was a reduction in costs by more than 3 times. And generally, the overall medical care costs decreased by 50%. In terms of accounting for operational and drug expenditure costs, the cost saving was 50% for anticoagulation service group. And when we quantify the direct and indirect costs, there's what is normally referred as indirect costs. For example, if a patient has to come to usual care, maybe they spend 4 hours. If you qualify and quantify the productivity within the 4 hours, maybe for a patient who is paid per hour 1,000, for the 4 hours that they are waiting to see a clinician, that is a loss of about 4,000. You extrapolate that with the almost 175 patients who are in the study. This is a very big cost to the patient, and also the time that they spend not going to work to attend the clinic. In the anticoagulation clinic service, they add significantly lower anticoagulation-related events, 14 compared to 41 in the usual care. In terms of hospital admission, there are also few, 3 compared to 14 in the usual care, and visit to emergency department was 58 compared to 134 in the usual treatment arm. The percentage of INR values range and percentage of time the INR values were in the range was significantly higher in the anticoagulation service, almost 67% compared to 54% in the usual care. And compared to the usual care, the pharmacy-led care, patients had more INR tests, but there were no significant differences in the quality, the quantity of drugs refills. In another study, there was a comparison of 2 different models of anticoagulation management services with usual medical care. So in this study, again, it is published in the Journal of Pharmacotherapy. The objective was to evaluate the safety and economic impact of 3 models of anticoagulation management: the usual medical care, a nurse-managed service, and a pharmacist-managed service. So there were 3 comparison groups: the usual care, nurse-managed care, and pharmacist-managed service. It was also a retrospective study. I'll not go through the details, but I'll go through the results because of time. So the outcome measures that this study looked at include anticoagulation indication, INR goal, rates and costs of hospitalization, emergency department visits directly related to anticoagulation therapy, and the markers of anticoagulation, that is time within range, and percentage of INR values in range. So the key findings, that in the pharmacy-led service, they had the lowest rates of hospitalization, both hospitalization and emergency department visits. In terms of hospital hospitalization, in pharmacy-led group, there was a reduction of 56% compared to nurse-managed 61%. In terms of costs, in pharmacy-led intervention, they averted a cost of more than $141,000 in terms of hospitalization costs and about $10,000 in emergency department visits, compared to nurse managed service where there was where they averted over $95,000 in terms of hospitalization and $5,500 in terms of emergency department care visits. The last study, this was one of the strongest studies. It was a systematic review comparing two common models of management for patient on warfarin therapy, pharmacy-led service versus usual medical care. And this was done in the smart search for literature in PubMed. So again, the outcome parameters were the same like the other studies. I'll go through the major results. So in the findings, that for those that were managed by pharmacy-led warfarin therapy, there was higher percentage that the patients were within the therapeutic range, which is 72% compared to 56% in the usual medical care. Looking at the major bleeding events, they were less in the pharmacy-led group at 0.6% compared to 1.7% in the usual medical care group. In terms of thromboembolic events, they were less in pharmacy-led group at 6% versus 2.9% in the usual medical care group. In terms of the number of hospitalization, they were less in pharmacy-led group at 3% compared to usual care group that was 10%. Emergency department visits, they were again less in the pharmacy-led group at 7.9% compared to 23% in the usual care group. So in all these outcome parameters, the pharmacy-led coagulation therapy had a significant impact compared to the usual group. So overall, the results show that the pharmacy-managed warfarin therapy model is superior to usual medical care in managing warfarin therapy based on observational studies. So in conclusion, we are saying pharmacies managed anticoagulation management services reduces the rate of anticoagulation-related emergency department visits and hospitalization with significant financial impact. So based on these results of these studies, it is important that we have a collaborative clinic which involve pharmacists, nurses, physicians, so that we can have an optimal structure for an anticoagulation management services. So it is upon us as pharmacists. We know we've been doing a lot for our patients, but there's no evidence on the ground to show our impact of the work that we are doing. It is time now that we need to document and also demonstrate to the rest of the healthcare workers what our interventions can do. And this can be done both in the hospital setting and also in those who are in the community pharmacy setting. So with that, shukran, and thank you for your attention.
Thank you so much, Daktari, for the very elaborate presentation. I guess it was so elaborate that we don't have many questions, But as Velma takes us through her presentation, I would invite you to look at the questions and see if there are some that need a direct answer. I can see already there's a question from Professor Julius Mwangi asking about Kitungu Saumu. I'm sure his field of practice, which is pharmacognosy, he has to relate it to every presentation. So you can go through the questions. I'll invite Velma to take us through her presentation, and we hope to be through on time. Velma, please.
All right. Thank you. Thank you very much, first of all, to the PSK team for allowing us to partner with you during this meeting. Thank you, Dr. Makori, for the presentation. I mean, you've really gone deep and partly covered some of the things that I was planning to present. And I'm hoping that the few slides that I'm going to share will have an additional reason as to why we would want to consider some of our patients on Xarelto and maintain them on therapy. So allow me to stop my video so that at least there's a clearer transition when moving from one slide to another. And I'm hoping that you will pick some good content by the time I'm done with my presentation. So, okay. So from there, so as introduced, yes, Velma Barca is my name. And from there we have Xarelto, oral anticoagulant. Rivaroxaban is a molecule, Xarelto is the name. And I just want to take you through a few slides that emphasize on why you should choose Xarelto as your anticoagulant of choice. Of course, we are at an era where we have several anticoagulants that are available for use for different indications. And we have been with you in the Kenyan market for about 10 years now. And we are still journeying with you in your patient care journey. And so we just want to take you through a few of these indications, yeah? So when a patient comes to you as the pharmacy, never look at yourself as just that other person who dispenses drugs, and but they're coming to you because they know you're going to offer them a solution for their problems. Of course, you have had in many instances where patients are coming to you even for diagnosis and eventual a definitive prescription to manage whatever condition that they are having, partly because they don't want to go to the doctor, maybe because of the cost, and because they trust you to give them whatever is best for them. And sometimes they're just coming in for refill. So the patients, or we as patients, we come to you at the pharmacy level, we're expecting you to give us the best choice of drug for whichever indication we're coming to that want to be managed. You to give us the right dose, or to emphasize the right dose and the right duration of treatment, and you to give us the best price that you can offer. Of course, we know the markups vary from one institution to another and from one pharmacy to another. And we trust you to give our patients the best price, the best dose, and give them the most effective information so that they can be well managed. And when it comes to Xarelto, we have several indications that are registered here locally. So we have the stroke prevention in non-valvular atrial fibrillation patients. We have prevention of VTE indications, post-hip or knee replacement surgeries. We have it for the treatment of the pulmonary embolism and also DVT treatment. And for the 2.5 milligram, I know some of your pharmacies, you stock the 2.5 milligram, which is the lowest dose of Xarelto that we have. And it is for the purposes of preventing atherothrombotic events in adults with coronary artery disease and peripheral artery disease, and also for secondary prevention in the acute coronary syndrome. So why we say Xarelto is because, as I mentioned, we have been with you for the past many years, 10 years and counting. And we're saying that Xarelto has been tried and tested in the different indications. So you can see for your atrial fibrillation patients, we want to prevent episodes of stroke and systemic embolism. For the VTE patients, Xarelto is recommended to treat the VTE and also prevent recurrent VTE events. And for the CAD and PAD patients, what we are aiming at is to prevent episodes of stroke, MI, and cardiovascular related deaths. And so I think just something small that Dr. Makori mentioned is that, of course, normally when patients are coming to you for refills, for those who have been on particular, especially these chronic illnesses, they will want that particular drug that they have been on for the longest time. And so they come, some of them, they come to you with the box, some of them with the blister pack, some with the name. And if you give them a different pack, and even when you have instances where the packs are changing, they don't appreciate the different package, yet it's what they have been taking. And it's just human nature. For chronic medication, if something is working for them, they want to be maintained on the same drug. And you have the category of patients who will come and say they want the original drug. So they have been prescribed an anticoagulant. I know there's Xarelto and others in the other rivaroxaban that we have in our local market. So some may come and just specifically say, I want the original product, because they know they are being managed on a very VTE management or AF management is a very delicate and the indication that needs to be managed the best way possible. So there's that category that will want the brand. And of course, they have the category of patients who have several comorbidities. And so they have that really long, extensive prescription. And as you're dispensing, they're expecting you to give them the best drug. And of course, the ones which they will comply to most is the ones that are simplified in dosing, maybe the once daily, in comparison to a patient who has, the drug which has to be taken 4 times a day. And it's just to emphasize that for you as the pharmacist, as you're dispensing this drug, these many drugs, it goes a long way when you explain to the patient the why they need to be compliant, especially for chronic medication, why they need to be compliant on treatment, why they need to take the drug as recommended, and why they need to be on the drug for the recommended duration. Because at the end of the day, we say life is the outcome that matters most, and we want the patients to have the maximum benefit of the drug. And for the anticoagulant patients on anticoagulants, the patients on Xarelto, we want them to have maximum benefit of the drug, which has been tried and tested, as I've mentioned. We have over 120 years. I think our oldest product is Bayer aspirin, which is stocked in a number of pharmacies countrywide. That's one of our oldest products, and it is still working. And of course, Xarelto is an original product. For those of you who might not know, is that the mother company is in Germany. And it has taken, it has been a journey to even develop rivaroxaban as a molecule from the inception phase. Then it became, it's not inception, but from the time the molecule was discovered up to the time Xarelto was now marketed as a brand name worldwide. So, and we're still growing in the different indications, and the research is still going on. So we're giving you a reason to consider something that has been tried and tested year in, year out. Some of you have benefited directly or indirectly. And so it is good for you to consider letting some of your patients, many more of your patients benefit from original product. So we've had this question raised severally. Why do the generics cost less than the original brand? Why do the generics of Xarelto cost less in some instances than us? First, we need to appreciate that the generic drugs don't really go through the extensive clinical research like what I have mentioned in my previous slide. And so the cost of the phase 1, phase 2, phase 3, and phase 4 trials, of course, it has to be recouped through the sales worldwide. And also the excipients vary. We may have similar molecule names, but the variations comes in the excipients, and the excipients is what will make the drug as good as it's supposed to be, and when you store it in the best way that is recommended and all that, so that the patient, by the time the patient is taking it, they're taking good quality medication. Some of you have had cases where maybe there could have been a report on you want to check if was it really your product or not, maybe it was a parallel imported product. The feedback we receive, we have one of your colleagues, Dr. John Mwangi, who's in charge of regulatory, goes an extra mile to find out, is this really our product? Was it manufactured at our site? Does it have the right excipients? And from there, then you get your appropriate feedback. So that is why they will cost less. And why do we say Xarelto? Because of course we have this support, as I've mentioned, we have support from regulatory affairs. We have Dr. John Mwangi, your fellow pharmacist. We have Dr. Jayesh Pandit, also a pharmacist who's in charge of pharmacovigilance. Any pharmacovigilance report, any safety and efficacy report that you may experience, that you may receive at your pharmacy, we love that feedback. We want to journey with you. We want to assure you that we are with you all the way. We are not just here to sell, but we want the patients to benefit at the end of the day. And if you have any concern, that is also our concern. So if you want to get feedback, reach out and we shall give you feedback accordingly, yeah? And so that is why we say Xarelto, start on Xarelto, stay on Xarelto. Xarelto is easy to use, oral medication. There's no need for anticoagulation monitoring, unlike the patients on warfarin. It's a simple drug approach, as I'll show in my subsequent slide. Simple, very simplified dosing. No dietary restrictions, unlike the patients who are on warfarin. Very few drug and drug food interactions. And of course, for the patients who are stable enough to be initiated from day one on Xarelto, there's no need for them to be admitted and go through the enoxaparin phase or the injectable phase of management, then discharge on oral. Or some of them may actually have to be admitted, but there's an opportunity for shorter hospital stay for the patients who can be maintained on Xarelto. And so when you talk about simplified dosing, this is what I mean. For the VTE patients, these are patients who have the deep venous thrombosis and pulmonary embolism. Recommended dosing is the first phase of treatment, which is very critical, day 1 to 21. Recommended dosing is 15 milligram as a twice daily dosing, 1 in the morning, 1 in the evening, to be taken with food. From day 22, the dose is stepped down to a once daily dosing of 20 milligram. But if they have moderate renal impairment, they can be maintained on once daily of the 15 milligram. Then there are those patients who may need extended treatment beyond 6 months because of the fact that maybe their risk factors are still persistent. And so if the risk factors are low, the doctor can maintain them on a once daily dose of 10 milligram. But if their risk factors are high and they have maybe additional comorbidities, then they are maintained on the 20 milligram once daily. Just as a point of emphasis, for the 15 and 20 milligram, it is your role as the pharmacist, as the last HCP contact to this patient, to emphasize with them to take it with food so that they can get the maximum benefit of the drug. For your patients who have non-valvular atrial fibrillation, for the purposes of preventing episodes of stroke, recommended dosing is once daily of the 20 milligram. But if they have moderate renal impairment of a creatinine clearance between 15 and 49 ml per minute, recommended dosing is 15 milligram once a day. Remember to emphasize, they need to take it with food so that you can increase the bioavailability of the product. Then I have mentioned we have the 2.5 milligram, the lowest dose of Xarelto, for the patients with coronary artery disease or symptomatic peripheral artery disease. Recommended dosing is aspirin plus 2.5 milligram of Xarelto given as a twice daily dosing. So aspirin is taken as a once daily, but the 2.5 milligram is taken as a twice daily dosing. So just a few slides to just remind you of a few features of Xarelto. Of course, as mentioned, it's an oral anticoagulant. Bioavailability is about 80 to 100%. And as I've said, for 15 and 20 milligram, this bioavailability is achieved if they have taken it with food. If they take it at fasting state, according to the pharmacokinetics of rivaroxaban as a molecule, the bioavailability is reduced up to around 66%. So the patient is not getting the maximum benefit of the drug. Half-life is 5 to 9 hours in the young patients and 11 to 13 hours in the elderly. Fast onset of action of 2 to 4 hours. And when it comes to renal excretion, we say a third of it undergoes direct renal excretion, but the 2/3 that remains in the system, 50% is excreted renally and 50% through the fecal route. Dr. Makori has already mentioned about switching. So should you have a patient who is on VKA and needs to be switched to Xarelto, and the doctor has recommended that, yes, this patient can be switched. For this patient, the INR, okay, you stop we know that properties of VKA is that it has a very slow onset and slow offset of action. So number one, stop the VKA, check the INR. For your VTE patients, if the INR is 2.5 and below, start Xarelto and give the dosing as recommended. If it's a patient who has a stroke, a non-valvular atrial fibrillation, once the INR is at 3 and below, then you can give Xarelto as a once daily dosing. There are those patients who may need to be switched from Xarelto to VKA for one reason or another. Maybe they have tolerability issues, or maybe where they are, for now, they cannot access it for one reason or another. So we recommend, because of the fact that Xarelto has VKA has a slow onset of action, this is the only time you're recommended to overlap to anticoagulants. So so continue to give your Xarelto, then and then you also start the VKA. Once the INR is at 2 and above, then you can withdraw Xarelto treatment and continue with VKA as recommended. If you have a patient who's admitted, I've mentioned that Xarelto has a fast onset of action of 2 to 4 hours. So the time that you give the patient is about 0 to 2 hours before the time they would have been given the injection. And the dosing is as highlighted in the slide, yeah? This is if it's the first phase of treatment. But if they're already on the once daily, then continue giving as a once daily dose. In terms of contraindications, just some highlights on contraindications. We don't have, for the current doses that we have in Kenya, none of them is recommended for patients who are under the age of 18. It's not recommended for patients who have severe renal impairment and those with prosthetic heart valves. It's not recommended also for the patients who are taking the strong CYP3A4 inducers, unless now the risk-benefit analysis is done. And also for the patients who are taking strong inhibitors of both the CYP3A4 and the PGP inhibitors, they're also contraindicated, such as we're talking about the azole antimycotics or the HIV protease inhibitors, yeah? So in the event of a missed dose, and the patient was taking the once daily of either the 10, 15, or 20 milligram, immediately they remember they need to take the drug and continue as a once daily dosing as recommended. If they were on the first phase of treatment where they're taking 15 milligram as a BD dosing, this is for the DVT-PE patients, then when they remember, they need to take both tablets so that they can get the maximum recommended dose for that particular day. Then the next day they continue taking one in the morning, one in the evening. If the patient was on 2.5 milligram, they should not double up the dose like the way you do for the 15 milligram. When they remember, they just take it. The moment they remember, then they continue as recommended. Once in moja asubuhi, the other one in the evening. In the event of an overdose, if it's around 2 to 4 hours after taking an overdose, then activated charcoal can work. Otherwise, for rivaroxaban as a molecule, above 50 milligram, will not be absorbed, is not going to be absorbed in the system. However, this patient may be at risk of bleeding, so they should be managed accordingly if there is an event of bleeding. So as I come to the conclusion, we have patient information material. We have this patient alert card, which I will highly recommend if you have not come across it, and you please reach out. Maybe I can get the information through the PSK team. It is good for you to dispense Xarelto with the patient alert card. And as you can see, it basically gives general information on what the patient should know about rivaroxaban, that it's an anticoagulant, what they need to watch out for because they are at a risk of bleeding because they're on an anticoagulant, and if they are and when they should reach out to the healthcare professional, and how they need to take it, yeah? Then on the other page of the small card, it's a foldable paper, yeah? So the patient can fill in their details and other medications that they are having, and the doctor's details in case of any emergency, because we know that these patients, should they be in a position where they can't express themselves and somebody gets to see this card, then they can be managed accordingly, so that they do, in the event of, just to watch out if they're, to avoid excessive bleeding, maybe if they need to undergo a surgical procedure as an emergency or something of that sort, and they're not able to express themselves, or anyway, they can just be handled in the best way possible. So as I conclude, for those of you who might not be knowing that we reduced our price by 50% countrywide, so that we have many more patients who are able to access the product at a good, affordable pricing. And this is the pack presentation for the 2.5, 10, 15, and 20 milligrams. So we only say that for your new to brand prescriptions, where applicable, where the patient has got relevant indications, start them on Xarelto, let them stay on Xarelto, because now the pricing is better than the way it used to be a long time ago. For the patients who need rivaroxaban refills, or their prescription reads rivaroxaban, I hope I have convinced you well enough for you to consider dispensing Xarelto and not just any other rivaroxaban that you may be having in your facilities. And so for more information, please feel free to go to thrombosisadvisor.com and interact with a lot of information there when it comes to vascular protection or venous and arterial thrombosis, just to increase your knowledge. And in the event of concerns, patients in terms of that is worth pharmacovigilance reporting, as I've mentioned before, we have Dr. Jayesh, who's in charge of our pharmacovigilance department, and the email is as you can see, pharmacovigilance.middleafricanpair.com. And if you have any medical inquiries, we have Dr. Isaac Kamau, who can offer you medical support, clinical trials, and any other medical related support that you would want. And so we say with Xarelto, it's protection that never rests, and the support that your patients need day in, day out. And we are here to work with you in this journey, in the patient care, as you take care of the patients. So I hope that you can continually consider to give your patients Xarelto, because we are here with you, we'll journey with you. If you have any questions or concerns, kindly reach out to us, and we will gladly journey with you. So thank you very much. That marks the end of my presentation.
Thank you, Velma, for that presentation. I'll invite you to also look at the questions. I think there are some interesting questions, especially regarding to the pricing of Xarelto. So you can look at the questions as I forward some to Dr. Jones. Daktari, I know there are many questions, but I would like to read one comment from Dr. Nyandoro. Good findings on the role of a pharmacist in anticoagulation. MTRH has a fully fledged anticoagulation clinic headed by a pharmacist. The clinic offers very good services. These findings have made the need to have many such clinics across our facilities. Well done, Dr. Makori. So in case I don't say thank you again, I think that reflects the feeling of most people. Daktari, quick question. I'll combine two on aspirin. Can aspirin 75 or 150 milligrams play a role here, that is in anticoagulation, though it is classed as an antiplatelet drug in anticoagulation therapy? That is one question on aspirin. There is another one. Can aspirin 300 milligrams from Amudwai Geoffrey be given as continuous course for patients, or is it given as a start dose only? You can handle that, Daktari.
Thank you. Let me start with Dr. Elizabeth's question about using aspirin 75 as an anticoagulation therapy. The answer is no. Main reason because if we look at where aspirin is effective as antiplatelet, and also it can be prevent aggregation or formation of a thrombus, but mainly it is in the arterial circulation and not in the venous circulation. DVT and VTE, we know the main problem is in the venous or the veins, not in the arteries. So it cannot be used for this purpose because where it is acting is different from where the other anticoagulants are usually, or rather we are finding use. For the other question, whether a dose of 300 should be used as a start dose or as a continuation, I wish I could know what the indication could be, but generally, lower doses are usually recommended for a prophylaxis as antiplatelets. Higher doses are used for treatment of other conditions like pain, but not for prophylaxis. And again, dosage can be individualized based on the patient factors and the patient response, but generally, lower doses are usually recommended.
Okay, thank you, Daktari, for that. I have another question. This one is from Prof. Let me ask on behalf of Prof, what can you say about garlic, that is kitunguu saumu, as a prophylactic anticoagulant? He's a pharmacist, yes.
Thank you, Prof. From my pharmacognosy, if I can remember, yes, garlic has some components that have anticoagulation properties, and normally people have used it for a long time to prevent coagulation. The challenge we have with what we can call crude drugs is that we cannot be able to define the correct doses. But if someone can extract the 4 active ingredients and actually the water soluble, and then make concentrates and convert into a suitable dosage form, then it can be used as rather for prophylaxis as an anticoagulation agent. So the issue could be, what is the dose? Would you take just 1 leaf of kitunguu saumu, or will you require the entire kitunguu saumu? So those are the issues that we really need to address, but it has the property of anticoagulation.
Dosing is the challenge. Thank you, Doc. To Velma, one Samson Juma is asking, can retail pharmacies and hospitals directly buy Xarelto from there? And as you answer that, please answer also if there are any access programs to make Xarelto easily accessible and available. That is from Dr. Osinde Cyrus, because he says that it's not pocket friendly. So you can handle the issue of price, Velma.
Okay, thank you for those questions. So issue to do with price, we have come a very long journey as far as price reduction is concerned. I remember when we started marketing it, those almost 10 years ago, price per tablet was I think almost 600 shillings. And now our trade price to the retail, to the distributors and the hospitals we supply to, the trade price that per tablet is 139 shillings, then less 10% discount, so that comes to about 121 or somewhere around there. We can say approximately 121 shillings per tablet as a trade price. We have access pricing. We supply to meds. We used to supply through KEMSA, but I think we are still waiting for them to give us an order so we can continue supplying through them. But through meds, I think a number of institutions are being serviced at very good pricing, at approximately around 70 shillings per tablet or somewhere around there. And so the markup of the prices varies from one institution to another, from one retail pharmacy to another. Unfortunately, we cannot control and dictate the pricing, but we seriously urge you to consider letting your patients have better pricing. Because if you're getting and we have been running bonus schemes as well, when you were for the customers that buy directly to us. So you might find that through the bonusing, if you're getting the tablet at almost 100 shillings, it's honestly not fair to the patient to get it at retail price of 270. Even though it's your mother, or you're buying for your patient, your family member, and just look at it from that perspective. So where you can avail the price at a better, Xarelto at a better pricing, having that the information that I've shared with you in mind, kindly do so. But at least we can say many more patients are able to afford, because a 50% reduction from the way it used to be. So many more patients can afford, but we still acknowledge the fact that there will be those ones who still will not be able to comfortably be maintained on the Xarelto treatment because of their financial status. Yeah. Okay,
as we are winding up, I'm not sure if you've commented on the bit of if hospitals and retail pharmacies can buy directly from there, or do you have your distributors?
We have several distributors. I think we supply to most major private hospitals. And when it comes to the distributors, I think we also supply to most major distributors. Of course, account opening is a process in itself. But if you just find out from your major distributors, like the Sagifams, the Laborex, the Harleys, the major, let me just say most major, we will supply to most major pharmacies, distributors, and they are at a position to share with you the bonuses or better pricing based on how they're buying the bonusing packages from our end.
Okay, thank you. One last one for you.
Eric, yes? Allow me to add something to what Velma has said, and this is Judy. I think one of the other things we picked was the chain of distribution. Sometimes you have a very long chain of distribution such that even from the Sagifam, Laborex, Harleys, maybe Nila, Transchem, or whoever, you are buying like from the third, fourth person. So we find that even if we give bonuses, they trickle down so slowly. By the time you get, the price is still quite, and do your markup, it's still high. But I think today we have a good number of them now are giving at good prices. So maybe just check, and at least now that you know the trade price, it's actually on net, it's around 125 per tablet in the market. For government institutions, mission hospitals, if you can get through meds, I think now the price is very good. And you can actually sell from around between 90 to 100 shillings. Thank you.
Thank you. We are closing, but I need a comment from you, Daktari. Comment on adverse effects sparsely reported on COVID-19 vaccine and venous thrombosis. If you have a comment on that. Dr. Jones? Daktari, you're unmuted, but we can't hear you.
Come up again. Sorry, the internet had a challenge.
Sorry about that. A comment, if you have any, on the adverse events sparsely reported on COVID-19 vaccine, specifically venous thrombosis, if you have a comment on that. Yeah.
Okay, let me first say that I'm one of the providers that are actively involved in following adverse events following immunization. And we have a few cases of people who reported events looking like venous thrombosis. But indeed, when we did the dimers and assessment, clinical assessment, there were no thrombosis in these particular patients. So the symptoms actually manifest as venous thrombosis, but on assessment, it is not a venous thrombosis. So far, of all the cases that have been reported, and after investigation by the Pharmacists and Poison Board, none of those cases actually were venous thrombosis. There may be signs of venous thrombosis, but there are no cases of venous thrombosis so far reported in Kenya, maybe in other countries.
Okay, thank you so much, Daktari, and thank you, Velma and Judy, their team. I think we can close at this point. We've overshot our time a bit, but I believe it was worth it. Thank you for partnering with us in this, and I think it was of benefit to our members. One last thing to our members, do not forget to subscribe on the PPB portal. Sorry about that. Do not forget to subscribe on the PPB portal. Our event today is on page 9. Find it before the token is sent to you. Then that's how you'll be able to get to earn your CPD points. Unless there is any word from Bear side. Judy, do you have anything to say?
Thank you so much, everyone, for joining. I always say the pharmacist is the most important person because you actually get to interact, the last person to interact with the patient. So let's make our patients just adhere to medication and even have no issues. Let them also know, because you guys actually get the most feedback. In case there are adverse events, in case there are any issues, you're the first. Most of the patients come to you. So let's have a way that we actually embrace them. We help them adhere to medication, and we'll have a very healthy population. Thank you so much, and have a good evening. God bless.
Thank you so much. Once again, thank you all for being part of this CME. At this point, I'd like to...
Before you go, just trying to type quickly. Just for those of you, for your information, there's a Xarelto bonus scheme that is currently running for this month of June. We have a bonus offer for Xarelto 15 and 20 milligram. The distributor level is 150 plus 30, but if you're taking it as retail is 7 plus 1. Then for those of you who are in the hospital setup, still for Xarelto 15 and 20 milligram, it's either 150 plus 30 or 50 plus 8. So we hope that you can consider to purchase within this month so that you can get the benefit of the drug, of the reduced prices. And this is still less 10% discount. So thank you very much for this opportunity. And thank you for just allowing us to host this meeting, and we look forward to future interactions. Thanks.
Okay, at this point, we all can leave now at our own pleasure. Bye-bye.
All right, good night.